to another episode of Keeping London Healthy. I'm Dr. Mario Elia. Today's topic will be skin conditions. We'll be talking to Dr. Tania Bhanji. So she is an adjunct professor in dermatology at Western University. She's a family physician with a focused practice in dermatology. So she sees a lot of skin conditions in her practice from day to day. We're going to be talking about a few conditions. So we're going to be talking about acne and eczema and perioral dermatitis and rosacea. So we'll be spending a bit of time on each condition and really addressing some, treatment options. When should you be seeing your doctor for these conditions? Because I know there's a lot of mystery about do I see my family doc? Do I need to see a dermatologist? So hopefully we'll be giving you some helpful advice around a lot of these conditions that you could potentially use for yourself or someone you know. So take a quick break, and after this message, we'll be talking to Dr. Bhanji. Welcome back. Again, we're excited to be joined today to talk about skin conditions with Dr. Tania Bhanji. So Dr. Bhanji is an adjunct professor in family medicine at Western University. And again, she's a family physician with a focused practice in dermatology. So we're happy to have her join us today. Hi, Dr. Bhanji.
Hi, thanks for having me.
So we'll start with acne. Obviously, kids going back to school. This is kind of a common thing with maybe their acne got a little bit worse over the fall. And obviously you see kids around with varying levels of acne in our daily life, and as a physician sometimes we think, we kind of wish that they would have maybe seen a physician, or did they even know to see a physician? So I guess the first question is, who should be seeing a doctor for treatment of their acne?
And I think a bit too often I'm seeing patients that come in with quite severe acne that have tried multiple remedies at home or have kind of YouTubed or Instagrammed some options. And it's unfortunate because I think there's so much we can offer at this point for acne that is so easily attainable that I think to answer your question, really, I think everyone should really reach out and see their family physician to talk about acne options, because a lot of times they're ending up spending tons of money on things that they may not really need to. And a lot of these treatments are thankfully covered.
So tell us a little bit about treatment options. So like if you were to see your family physician and severe enough to warrant treatment, which again, even mild acne warrants treatment. Tell us a little bit about treatment options. Where would you start with these patients?
The most important thing that I want to talk to patients about is their skincare routine. So I think the foundation being, are you using something consistently in terms of a cleanser? Do you moisturize? A lot of people think that with acne, it's oily. Why do I need to moisturize? But in fact, you do, and to replenish that skin barrier. So I spend a lot of time in any visit just talking about basic routine of skincare, keeping it simple, don't use too many fragrances, and something that you can use consistently and regularly long term. So that's kind of where I start. And then in terms of treatment options, and we can kind of get into that, there's a whole bunch of options, whether that ranges from topical treatments, oral treatments, and then, more fancy techniques that we can use for scarring. So I think ultimately skincare is where I usually start. And usually sometimes that's all it takes and they get much better. There's a lot of great cleansers on the market, for example, that have active ingredients. And those are enough to treat mild acne.
So let's start with topicals. Because obviously that's for the majority of patients with kind of mild, moderate acne, we start there. What are some kind of classes of medications? What are some approaches that you take with these patients?
When I assess a patient, I usually try and determine the severity of their acne. So there's various grading mechanisms that you can use, the simplest one being mild, moderate, and severe. And we classify that by the type of skin lesion. So if they're having blackheads and whiteheads, so those are what we call comedones, that's considered kind of grade 1 or early acne. So that the baseline for any acne treatment is a retinoid. A retinoid is a vitamin A derivative, and that is a topical cream that they can apply. Now, that being said, there's some irritation that comes with that. And that's part of the counseling, is that we slowly work their way up from every other day or every third day to daily, and talking about the importance of skincare and moisturizing with that. So retinoids would be the baseline. Now, if they have more moderate acne, so that's when you start to see more red. So, pimples and papules that are a little more pussy, the redness on the skin. Whenever you see red, you're concerned that there's going to be scarring, and that's inflammation. So you want to use an anti-inflammatory. So that can come in a couple different forms of topicals. There's a benzoyl peroxide, which is also available over the counter, and or antibiotics. And sometimes we combine both depending on the severity. So First, we start with the retinoids. We work up the ladder, add in some anti-inflammatories. And then after that, other topicals that are a little more fancier coming out these days, but I'll leave that for another day.
And any precautions with benzoyl peroxide specifically that you would
Yeah,
advise?
absolutely. So benzoyl peroxide is a bleaching agent. So it's one of the things that I caution patients about. Oftentimes I try and end up putting it into a cleanser format so that it's not a lot of contact on their skin. But if they are using it as a cream base, it will bleach their clothes, it will bleach their towels. So I'm quite cautious about that. And the other thing that is important is, making sure that patients are not using only a topical antibiotic. There's a high risk of resistance with that. And so trying to combine the retinoid or benzoyl peroxide with the antibiotic prevents that.
It'll bleach fabrics and that kind of thing. Won't bleach your skin, so don't worry that we're not prescribing any skin bleaching agents. So if topicals don't work for patients and we kind of transition to oral medications, what are kind of some options there?
There's a lot of options for orals, and it depends on the type of acne as well. We try and classify, yes, mild, moderate, and severe, and then we try and see if there's a hormonal component. So for females, for example, if there are high androgens, if they have atypical menstrual cycles, if they're noticing truly that they only have acne during, pre-menstrual situations, then we try and end in anti-androgen. So those come in two forms. There's the birth control pill, or you can use an anti-androgen such as spironolactone orally. So that's one option. If there have very intense inflammatory papules, pustules, cysts that you're seeing that require, drainage at times, you probably want to add an oral antibiotic. And so there's a variety of those. Recent studies are showing that, we've been using them so much that there are resistance patterns. So we're trying to stay away from the erythromycin, the clarithromycins, more towards the minocyclines, tetracyclines, doxycyclines, which have less resistance patterns in Canada and in North America. So oral antibiotics. And then after that, we're talking about isotretinoin.
Spironolactone, especially, you mentioned that. Good option for women if you're having fluid retention and maybe some hair growth that they don't want and acne. It's a good combo because it'll do multiple things. Spironolactone lowers blood pressure, so again, if someone's hypertensive with these issues, even better of an option. In terms of the doxycycline, any advice in terms of seasonal? Like, are there? Because I know sometimes you can get obviously some patients can get a rash in the summer from the doxycycline. Do you have any advice around that? Do you prescribe it in the summer at all, or mainly kind of
Yeah,
fall?
absolutely. It's a good question. Any antibiotic will give you some photosensitivity, but doxycycline specifically creates an extreme photosensitive reaction. And it's really important to review the other medications that they're taking because there's some certain medications, example being hydrochlorothiazide and doxycycline, once combined, can cause a very severe reaction on the skin. So do I prescribe doxycycline in the summer? Yes, I do. I give a lot of caution and advice about sun protection and barrier protection. And the other most common side effect that people complain about is just GI irritation. So they get a bit of diarrhea, abdominal discomfort. So taking out food does help.
Any birth control pills that are more effective than others for acne that patients should be kind of
Yeah, absolutely. But what we're trying to do with birth control pills is really decrease the androgen levels. Now, there's so many different birth control options out there that actually end up having higher androgen levels, which can actually exacerbate acne. So we want to use something that has low androgen. So the few that are approved for acne specifically would be Yasmin, there's Lanessa, tricycline. But again, some of these may be discontinued. So best to speak with your family doctor to confirm, what would be their best option for that.
So people would have heard various things about Accutane, which is a pill we prescribe for acne. When do you typically prescribe this for patients?
Just to talk a little bit about Accutane in general. So Accutane is the brand name, right? And so that was what was first launched back like 50 years ago. Oral isotretinoin is the generic name for it, and there's various forms of it now. So oral isotretinoin essentially is an oral form of vitamin A or retinoid, and it comes now in Epuris and in Claris. Epuris is kind of the more advanced form, which does not be affected by what you eat. So Accutane used to be super dependent on what you ate, and you had to have a fatty meal, which oftentimes teenagers, who are the most common patient, don't do. So we would know that, is this really a treatment failure, or is it truly because they're just not eating right? So Epuris is nice. So oral isotretinoin, when do I use it? Oftentimes it's for severe cases that have not responded to either topicals and orals together. But sometimes patients come in and their severity of acne is just so intense and they have deep scars or cysts, and we start that right away. I think a lot of times patients have had some fear about it because there's a lot of social media and newsprints about, it increases the rate of depression. It can cause a lot of side effects that people are scared about. But I think with lower dosing and the new technology, it's a lot more tolerated. Patients don't complain as much. And I think at this point, the idea of it increasing depressive thoughts and suicidal ideation has been debunked.
Certainly, and I've got a number of patients who had really severe acne, did really well on Accutane. So definitely kind of hopefully reduce that stigma around prescribing isotretinoin. So if someone has scarring from when they were younger, perhaps before they were treated, we know none of the treatments that we give now can really reverse scarring too well. What are some options for these patients?
It's important to kind of classify the type of scarring that they have. So there's two types of scarring that patients can have. It's either atrophic scarring, where there's a loss of tissue, or hypertrophic scarring, which there's an increase or kind of growth of tissue there. Most often with acne, you're seeing atrophic scarring, which is a loss of tissue. And there's various depths for that. And there's three different kinds: ice picking, box scar, and rolling scars. And depending on the depth of it is really what we want to kind of figure out what the best treatment would be. So for more superficial scars, really, I think the most important thing is a topical retinoid. A retinoid will help kind of do that exfoliation, regenerate. It does, and it's great for both pigmented scars, atrophic scars, and it prevents acne. So really, it's my baseline for any one that comes in through the door. The newest study shows that there's a specific type of retinoid called TAC2 Pump Forte, which actually has benzoyl peroxide and the highest strength of adapalene, which is a type of retinoid. And that's been proven to actually improve acne scars. So that's kind of where I start if they can tolerate it. And if they're getting, much deeper loss of collagen, they probably need some surgical treatments there. So I usually often refer to our plastic surgeon colleagues to see if there's any options for them, because there are certain lasers and surgical techniques that kind of improve those deep scars. But oftentimes it's time, good sun protection, and good exfoliation does the trick.
And just a reminder to patients that most family doctors should be able to treat most components of acne themselves. Like, I know we have patients coming in asking to see a dermatologist right away because they think that only dermatologists can treat their acne. But again, most family doctors are probably comfortable treating at least most components of this. So don't be afraid to reach out to them. So we'll transition away from acne and just a few minutes on rosacea. So rosacea is a condition obviously we see time to time in family practice. What would you say rosacea normally looks like? How does it present to patients?
So rosacea is interesting because a lot of people don't even realize that they have rosacea. And so really a lot of education and identification in the family doctor's office is important. So rosacea comes in four forms, and they can overlap and they can be on their own. So the most common form is something called Populopustular Rosacea. So that's a type of rosacea where you have little pimples. They're not whiteheads or blackheads. They're really just little pimples under the surface of the skin. And they can be a little bit irritating and they can feel like a burning and itchy sensation. The second form that is also common is called Erythematologistic. Now that is when you see redness, and that can be due to broken little blood vessels under the surface of the skin that give patients just an appearance of it being flushed and always rosy. Oftentimes it's worse if they're out in the sun, in the heat, after shower, if they drank anything spicy or hot. Alcohol can trigger it, exercise, and that's usually seen together with the papulopustular, but can be on its own as well. The third form is ocular rosacea. So a lot of times patients will come in and they'll be complaining of just a gritty eye sensation, and it's itchy, and they're not allergic to anything. And you've done that whole workup. And it truly is more of a dry eye. Their oil glands are starting to, be inflamed, and it leads to that grit sensation. And then the final one that is a little bit further along and more common in men is a type called Rhinophymatis. And that's when you kind of start to see this cobblestoning of the nasal alar area. And then they start to actually grow more tissue in that area. So you can have one, you can have two, you can have all four of them.
So you mentioned a few things there. So kind of non-medication approaches to certain types of rosacea. So avoidance of alcohol, avoidance of spicy foods, that kind of thing. How would you decide to start someone on treatment, and how would you kind of decide between topical and oral medications for these patients?
So I think if you're seeing a patient for the first time and they have papulopustular rosacea, that's a lot of inflammatory disease there. So you really want to start them on a topical treatment. But if it's affecting more than just their face, you can have rosacea that's extrafacial rosacea. So So it could happen on their scalp, their chest, their arms. And if that's happening, you probably want to start them on an oral treatment simultaneously to really get things under control.
And the oral medication most often we give would just be an oral antibiotic for these
Exactly.
patients most of the time. And again, there are some topicals, topical ivermectin. One of the few reasons we give ivermectin, and one of the effective forms of ivermectin would be for rosacea. So again, and this is one where, again, talk to your family doctor, because they would be the ones. Again, there's lots of options. We won't get too far into the weeds, but lots of good options available for treatment of rosacea. We're just going to take a quick break, and when we come back from this message, we will talk a little bit more about skin conditions. All right, welcome back. Again, we're being joined today by Dr. Tania Bhanji, who is a family physician in London with a focused practice in dermatology. And we're talking all about skin conditions today. So we'll jump right into eczema, which is obviously probably the most common thing that patients experience that we see in practice. But some patients really kind of aren't confident in how they should be treating it and what they should be doing. So for the average patient with mild eczema, where do we start with treatment? What could they be doing on their own even before they see the doctor?
Yeah, I think that's a great question. And I think at this time of the year, specifically, given the seasons changing, a lot more hand washing happening, going back to school, we're going to see a lot more eczema. So most often patients do have mild eczema. And I think the best place to start is with topical moisturizer. So we talk about kind of making sure that you protect your skin barrier. A lot of times when I ask patients, they're not even using a moisturizer after they come out of the shower. And I think that's probably the easiest place to really seal in that moisture, get a good barrier function going so that they don't have the insults of the environment making their eczema potentially worse. So we really want to limit the amount of contact with water. We want to make sure that they're bathing or showering in more tepid water rather than really hot. Oftentimes patients with eczema are so itchy that they just love that heat on their skin, and that's the worst thing that they can do for it. So we really want to make sure we're educating them on simple measures that can prevent and treat mild eczema. The other thing that's important also to recognize allergens. So oftentimes there's certain contact allergens like fragrances or even nickel allergies that can really exacerbate and start up eczema. So just being aware of them, avoiding those things, and they can be hidden in products. So you can be buying things for over the counter that you're not realizing could actually be allergens and irritating your eczema.
Any moisturizers specifically that you would suggest, and how frequently would you be applying these things?
Eczema Society of Canada has a great link on their website about all the topical moisturizers that they recommend. And so the ones that they often talk about are Aveeno. There's a Aveeno eczema line. So the colloidal oatmeal actually in their products improves barrier function and decreases inflammation. So that's really a nice way to start. There's also great lipid replenishing moisturizers from CeraVe and Cetaphil, as well as Aven has a line called Xeracom. I think, looking for that seal of approval of Eczema Society of Canada on the product would be an easy way to start, and making sure that you moisturize at least twice a day, definitely after the bathing and showering, if not 3 times.
It's important because people use so many different kinds of what they think are moisturizers that are actually making things worse. So definitely sticking to the Eczema Society of Canada there. If someone has tried, so obviously we prescribe topical steroids for flares. For patients, are there newer treatments that are available for people who failed topical treatments for their eczema?
Yeah, there's a lot of new advances that are happening in the oral department. I think one thing to talk about as well is there's not just topical steroids for your topical treatment of eczema. There's also our non-steroidal kind of maintenance options that come in the form of calcineurin inhibitors such as Elidel or Protopic. And then there's a newer line called crisaborole or Eucrisa, which is a topical that we use more often for mild to moderate eczema as maintenance. And that's more of a anti-inflammatory, non-steroidal, because oftentimes people just use steroids forever, and that's probably not ideal long term. So these are nice topicals. But to answer your question about oral treatments, yes, there are new treatments. Something called dupilumab or Dupixent is an oral anti-inflammatory that works very well for eczema. And then there's a new study that's coming out for JAK2 inhibitors, both topically and orally, which actually specifically target part of the inflammatory cascade in eczema that has shown quite a lot of promise. So we're looking forward to more studies and approval on those.
So we're going to transition to the last condition we're going to talk about today. And this is one that I I can say for myself, and you'd probably agree, drives us a bit crazy in practice because patients don't know about this condition. It's called perioral dermatitis, and it's one where patients will often try to treat themselves and potentially make things worse before they actually see us. So again, what does it commonly look like? So what is someone with perioral dermatitis? Or what does that rash look like?
Yeah, that's a great question. I think this is something we see both in family practice and just in general, seeing patients outside of the practice often. And it is, and I think the reason why it's so often misdiagnosed is because it looks like a lot of other conditions. So it can look like eczema, it can look like rosacea, it can look like acne. It's these little red bumps around the mouth. It can be around the nose or the eyes. And that's what's called perioral dermatitis when it's around the mouth. Now, it can actually occur around any orifice, and that's when we call it periorificial dermatitis. So it can happen around the anal area, around the eyes, and it looks like red bumps. But the most important part of the history is asking about the symptoms. So usually patients do not complain with rosacea that it feels like an itchy burning, but they do with perioral dermatitis. Acne doesn't itch, it doesn't burn, it just hurts. And so that's the differentiator. And so taking a good history, doing an assessment, and making sure that there are no exacerbants. So a lot of times patients come in with perioral dermatitis and have tried to remedy themselves by buying hydrocortisone at the pharmacy, and it actually makes their condition worse. So that's the most important thing, is asking the history, looking for those kind of red bumps that look like acne around the eyes, nose, and mouth.
Absolutely. And if there's one thing people can take away from this episode, do not put hydrocortisone cream on your face in response to a rash. It's tempting if you have it from before, from some prescription you got, but it will make this worse and will be difficult to come off of because they'll flare. So please don't put cortisone on your face if you've not been told to by a doctor. What are some treatment options for perioral dermatitis?
Yeah, so of course we want to remove any irritants. So if they are using hydrocortisones, we want to stop those. And oftentimes I get asked, do you wean it? Do you stop it? I just stop it cold turkey. You stop it right away. If you the longer you use it, the worse it will get. And the other things to just ask about oftentimes are toothpaste. Sometimes toothpaste can exacerbate the condition. What kind of makeup are they using, or moisturizers around their mouth area that could be exacerbating if there's perfume? So we want to kind of eliminate those triggers. And then topical treatments are again, calcineurin inhibitors, which are a non-steroidal form of anti-inflammatory in the form of Elidel and Protopic that really works effectively. I usually prescribe it twice a day initially to really get it under control, especially if they've been grumbling along, which they often have before they come to see us, for a few weeks, and then they can wean down to once daily and then as needed.
Well, thanks so much for joining us today, Dr. Bhanji. It was super helpful getting your advice on so many skin conditions. And hopefully people are inspired to see their family doctor to address some of these issues, because I know they can have a big effect on someone's quality of life, and especially when we have good treatments available. So again, thanks for joining us.
Thanks for having me.
And thanks again to Dr. Bhanji for all of that helpful information. Just a couple quick points about COVID. Obviously, things are kind of continuing to evolve. As we come into the fall, I've been asked by a number of patients about boosters and what they should be doing around that. My general advice is if someone's certainly a high risk demographic. So if they're a senior, if they have a high risk medical condition, they certainly should be getting a booster. In terms of whether to wait for the bivalent options or to get them now, there's really no wrong answer. But just so people know that there is a lot of COVID going around right now. Again, this is being taped on September 9th. So as of right now, I would say there's probably more COVID going around in the community than there has been at any other point during the pandemic. Again, thankfully, with most people being vaccinated, and at this point, a lot of people have probably had COVID themselves. We've got a good amount of immunity in the community, so the risk of hospitalization, thankfully, is fairly low. But just so people know that there is a fair degree in the community. So if you are somewhere where masking isn't too much of an inconvenience, we generally would recommend masking. So again, grocery store, pharmacy, sporting events. If you don't mind wearing a mask and you want to try to prevent getting COVID, probably not a bad idea. And it's important for people to know too that if you are a senior, or you are not, if you've not had all your vaccines, or you're immunosuppressed, there is a medication available to reduce your risk of hospitalization called Paxlovid. Still, I'm finding that a lot of people don't even know that this is an option. So again, if you are a high risk person because of either being under vaccinated or immunosuppressed or a senior, please reach out to your family physician as soon as you can upon learning that you are positive for COVID, because we can treat you for these conditions, for COVID, and we can reduce your risk of hospitalization. So it's called Paxlovid is the name. Okay, that's it for today's episode. And until next time, stay healthy.